Hello everyone, so welcome back. This is Health Economics. So starting this chapter, we are going to shift our focus completely off from the healthcare markets. So instead of talking about the markets, we are going to mainly focus on public health policies. So far we have learned a lot about the healthcare markets or the medical markets in general. Learn about the behavior of the demands for the services and goods. We learn about how the healthcare markets works, the supply side of the healthcare markets, the insurance market specifically. We actually discussed about several issues that we found in the asymmetrical market settings. What are the solutions or possible solution to limit the problem of moral hazards and adverse selections? Well, now we are going to mainly focus on the discussions for how a country or a nation can form a optimal health policies in order to achieve the optimal level of wealth, health, and equities. So in chapter 15, we are going to actually take a look at some of the issues faced by every single nation in the world related to the healthcare policies. And then we would like to actually think about how some of this issue can be solved or can be resolved by certain policy. And we would like to look at some of the trade-off for those policy and trying to compare them one by one. And at last, we would like to actually take a brief look of some of the common national health policy around the world and trying to understand, well, what are some of the benefits and trade-offs by setting certain policy provisions in the country. So first, I would like to actually talk about some of the things that we already learned from the previous chapters. So in general, the healthcare markets actually have many issues that we have discussed, such as in the market of healthcare services, lack of competitions will create oligopoly pricing for hospitals. So not enough supply of physicians or not enough supplies of hospital will creating monopoly power or oligopoly powers so that they will be able to have some degree of price control in the markets. And that will actually drive up the healthcare prices in the market. Other things also contribute to the imperfect market settings of healthcare services, such as the monopoly rents for doctor and specialists, because the doctors and specialists, they are so limited in the markets, which makes the doctor to be able to exercise the monopoly powers or maybe influencing the governments to continue to maintain the monopoly standings in the market. So those actions taken by the physicians, doctors, or specialists are basically waste of the resources. It's kind of like a loss of welfare. And also the medical arm races, it's the extreme versions of the reverse of monopoly. So sometimes some country might have a market for healthcare services. It's overwhelming with competitions where competitive firms in the markets, they might actually trying to eliminate their competitor by issuing or maybe offering the excess of this healthcare services in the markets, which in this case might actually overuse the efficient level of healthcare services. Well, on the other hand, not only the market for healthcare services might have its shortfall with the competitiveness of the markets, but The health insurance market will also create its own problems for both the healthcare services and also the overall expenditures on healthcare in the nations. Well, we will talk about the adverse selection problems where people trying to hide the informations, taking advantage for buying insurance. Well, that will create a problem of failure of insurance company or firms and causing less firm to be available in the markets, and some populations in the country might get into a problem for having a no insurance or under insurance in the, of the protections, so that people might suffer with this high expensive cost of healthcare services. On the other hand, the moral hazard problem actually creates another issue where the people changing their behavior after buying the insurance, and that might actually drive up the total expenditures of healthcare by overusing the technologies, or maybe using the available resources in the society. So again, all this problem that we have studied in the past all contributes to a very fast-paced inflated health expenditures in the modern worlds. So health policy or public health policy basically are designed to deal with all these problems. But every new policy creates new problem by itself. So not all policy are able to, or it's able to eliminate all these issues that we've studied in the past chapters. Some of them can provide benefits, but the benefit doesn't come with no cost. Well, when we talk about the optimal national health policy, well, of course, we always think about there will always be one policy that will make everyone happy. However, we do have an economist actually suggesting it's not totally true that we will always find this one optimization policy that can solve the problem for everyone. And this theorem is called the Arrow's impossibility theorem. So the Arrow's impossibility theorem basically suggesting there might not be a optimized solution to everyone in the society. Just like how we study in chapter 3 when we talk about the Grossman models, well, just like an individual will taking time to decide whether they want some level of health given the investments on health, or maybe putting those resources to get the market goods to enjoy from other types of goods instead of health. Well, the society also making those decisions simultaneously. So the society, they must decide how much time to spend or how much resources they should spend in order to improve the health of the populations. So all these resources spent can also be spent on other things. So basically, it has no difference comparing to an individual's decisions makings in health. However, given the fact that every single one in the society might have its own preference for choosing what they want most, well, it's not necessary that they will always come down to one specific conclusions that everyone will agree. So for example, let's say we have a society where there are 3 individual peoples living in the society, and every single one of them has a transitive preference. So what is a transitive preference? Basically is a preference where the individual will rank what they like most for certain things in life. So given an example here, let's say individual A prefer chocolate over chips, and also individual A prefer chips over banana. On the other hand, well, individual C prefer bananas over chocolate, and chocolate over chips. But given the preference here in the society, everyone has a very clear preference. Well, it's not necessarily means that they will always pick one policy that will satisfy everyone in the society. So for example, let's say, well, we want to actually try to think about the logical sense. Well, is there any things in this three products in the society that most people will prefer? Let's say we're looking at chocolate. Well, it seems like individual A and individual C, they both prefer chocolate over chips. So that means if that's the case, well, at least if the society providing chocolates to these three individuals, individual A will be the most happy. Individual C will also prefer chocolate over chips, even though it's not banana that he would prefer the most. But seems like it's not going to upset both of them because, well, only individual B value chocolate the least. Well, is providing chocolate is the best thing? I would say, well, we have to take a little bit more of a look here. So let's suppose we are looking at the choice of chips. So in this case, well, individual A actually prefer chips over bananas, and individual B prefer chips over banana. Well, since this two individual actually prefer chips over banana, so it seems like banana is the least preferred choice. And also in this case, well, since chocolate is preferred over chips from the previous examples, and chips is preferred over bananas, so it seems like the transitive preference in the society is chocolate is superior, and then the chips will come next. But it's banana actually the least preferred in the society. Well, what about if we look at the choice of banana? It seems like individual B and individual C, they both have the preference where banana is over chocolate. So now it becomes a weird sense of problem because, well, it kind of get into the loop of, well, there are two individuals will prefer one thing over the other, but then it's the same for other products where there are also two individual persons will prefer another product as comparing to the third persons. So this loop will never end it because there is no superior choice that we can clearly find in this society, even though every single individual here in the society has a very clear transitive preference. So the conclusion to this dilemma, basically, there is never a solution in the society. Even every single individual has his or her own transitive preference. So the conclusions of arrow theorems basically speak out as the following. So it does not make sense to speak of an optimal health policy for the country because the societies actually may not have a preference that can be optimized in the traditional sense, where we believe people prefer something over another, but it might not necessarily true if we're looking at the population as a whole. So even though that's the conclusion we made, or we actually see from Arrow's theorem, but it does not stop the governments to actually formulate an optimal health policy for the country. So for the following sections, we are going to assess this policy by analyzing how well they meet the three board goals that we actually construct in order to evaluate the effectiveness of health policy, which is health, wealth, and equity. So health basically represents the health level of the populations. Wealth represents, well, how much of the total wealth in the nations can make purchase of other goods as comparing to the health expenses. Well, of course, if you see the health expenses, it's inflated to a very high level. That means in general, people are paying a lot of their incomes in health expenses. Well, even though they have a better health, it does not means they are more happy, because they are losing the opportunity to purchase other things. And equity is the third element that we would like to achieve as a government. Well, of course, equity can be very difficult to define, but hopefully we can find some sort of evaluation to analyze it. So this assessment cannot reveal which policy is better or superior comparing to the other, because well, every single country has its own conditions. We can only study the trade-off inherent in the health policy in this chapter. So in this sections, we are going to actually talk about the policy trilemma. So there are several things that we would like to achieve in any public policy. And this three elements that we talked about earlier basically are the trilemmas in healthcare policy. So in general, we're always trying to achieve the maximums of health, the maximum of wealth, the maximum of equity in any policy or healthcare policy specifically. But the thing is, with the scarce resources we have and the imperfect competitions markets of healthcare services, and also the asymmetrical information of the insurance markets, well, it's hardly be able for a country be able to actually achieve all three goals at the same time simultaneously. And what's true to be find out in the reality is most of the time country actually needs to make trade-off between these three goals that we always trying to reach. So for example, it's possible to have a hypothetical policy that actually fight off those adverse selections in order to increase the equities of the social or the society for getting access to healthcare services. But by having those hypothetical policy, which means the healthcare costs will inflate it dramatically, because if equity it's being provided with low cost, then well, obviously everyone would like to actually use those services. And at the end of the day, well, the government will have to pay off those bills, and the money from the government is actually generated from the tax dollar. So it basically it's a cycle where the resources of the society will ultimately contribute back to the overuse of those services. So when we achieve equity, we might actually need to take away some of the wealth in the society. When we are trying to achieve the wealth, well, then we might actually take out some of the health and also equity in the society. If we're trying to achieve maximum health, well, we might actually need to take away a whole lot from wealth and equity. So any public health policy actually it's facing this problem of a trade-off between these three goals. So there is never one that can speak out of all the countries in the world. So since there will always be a trade-off between all these three trilemma, so there will never be a perfect healthcare system that fits all the country, and there will never be a perfect healthcare system that can always achieve all three goals simultaneously. So furthermore, people actually disagree how important one of these goals is superior comparing to the other. So some country, they might actually think that providing equity access or equal access to healthcare services is the most important policy goal in the country, and they are willing to pay a much higher level of expenditures or tax in order to achieve that. Versus there might be other countries that might actually think that they will value the health the most instead of equity, and they are willing to actually tolerate more on moral hazards and monopoly pricing in order to secure all these new drugs or new treatments, new developments of healthcare services to come into the markets. So this trade-offs, it's ultimately going to be the very subjective things to look at for each country. But the idea is if we can actually achieve, well, all three of them in certain level, we are willing to actually assess whether some country is doing better than the other, well, which we are going to talk about the assessments of healthcare policy at the end of this chapter. So the key for healthcare policy choices are basically the trade-off between health, wealth, and equity. So the policy options that followed to the present and answers to be three broad questions that any nation's national healthcare system they must answer. So the three questions are, number one, how should the insurance market work? And number two, how should moral hazard be controlled in public insurance? And number three, how should healthcare provider markets be regulated? So we will break down those three important questions into three different sections so that we can actually get a better sense of how public policy actually address the problem in the society. So we have actually learned a lot about the health insurance markets in the previous chapter. So now we are going to summarize some of these findings and trying to provide a understandings for how the public policy will adjust those problems. One of the biggest challenge in the insurance market is the face of adverse selections in the markets. But because of the asymmetrical information between insurer and their customer, there's a potential to destroy or severely limit the private health insurance markets. So one fundamental idea that forms healthcare system is how should the government address insurance in the society. There are several options or solutions to that problem, but all of this option does not come with no cost. So we always have to balance the three trilemmas that we actually mentioned: the health, equity, and wealth. There's no one solution to address all three of the goals that we would like to achieve, but particularly some might actually work well with particular country, and others might actually work better on the in the other healthcare system. So remember, there are 5 options that's being discussed in the textbook. They are not mutually exclusive. It's not like we apply one to a country, we cannot have the other ones apply simultaneously. It can be the case where the country actually employs several of these options into the country. For example, taking the case in the United States, we do have a universal public insurance to cover the elderly and also the low-income family. We do have a compulsory insurance system, and we actually apply also the employer sponsors insurance in the country. So let's take a look at this chart right here. Well, this actually illustrates the two extreme policy that actually answer the questions for achieving the three trilemma. So we have one end where the government can completely make everything private. So we have a private insurance markets, and the government basically just let go of the insurance market and let the market run by itself. On the other hand, we have the universal insurance system where the government actually take over the insurance market completely and not having the private worlds to run the market itself. There are other policies that actually stand between the two extremes here, which we are going to go through them one by one. So in the case of option one, where the private insurance market is being implemented to the country, well, the pros for this types of policy is because the government is playing a very minimum rule in the insurance market. There is no additional cost to the government, which means they can keep the tax payments very, very low to the citizens. And also, minimum government interventions, it's always expected when the government not taking any actions in the markets. So it actually have the minimum interventions from the government that might possibly or sometime potentially affecting the equilibriums of the markets. However, it comes with a cost. So the cost for this type of market system is the maximize of the adverse selections in the markets. So think about an unregulated insurance market where the consumers of the insurance will hold most of the asymmetric informations on their own. It creates this consumers in the insurance market to take advantage to hide those necessary information from the insurance suppliers. Also, this adverse selections might end up leads to a debt spiral experiment that we study, which leads to an insurance for everyone in the markets because the insurance company will ultimately adjust the premium and coverage according to the average cost paid to the insurance buyer. And the pool of the insurance buyers will getting smaller and smaller because they will have no excuse to buy any insurance when the premium is setting too high. So ultimately, it will actually lead everyone's back to the markets with no insurance at all, and everyone has to pay out of pockets. Well, in the worlds that we live in, so far we don't actually see any developed country actually apply this private insurance market completely, basically let the market run by itself. Indeed, in some developing country, it might be still the case where the government is giving a very open degree of freedoms to the insurance company. But in all developed countries in the world, this policy does not exist. In option two, which is the other extreme of the spectrum where the government actually take over completely the insurance market, is to provide this universal public insurance. So the good thing about this type of policy is, well, it actually sidesteps the adverse selections and ends all the uninsurance scenarios because, well, now the government will promise the publics to have everyone's covered by the public insurance program. Provides equities and also ensure everyone will get access to the similar standard of care. That's basically the fundamental objective for this type of insurance policy. Also, it reduces all the non-health related costs, such as advertising or any kind of expenses that related to the market competitions in the insurance market, because now every single insurance provided to the public, it's run by the government, so there is no competitions. Well, without any competitions mechanisms, well, now the government can mainly focus the expenses on health-related expenditures instead of spending money to actually promote or advertise the program. So it's in general believed that this type of universal public insurance, it's more cost-effective comparing to the private insurance market because of the cost saving from competitions. But it comes with a cost. It's not like this is the perfect system that it's not going to cost anything to the society. Providing a maximum level of public insurance in a country, which also means that people will take full advantage of this insurance, and everyone in the country will maximize moral hazards. So, for example, when you feel sick in the country and the government actually promise you, whatever problem it is, we will actually pay for your expenses. So even though you actually feel a little discomfort from your work, you might actually want to be sure that you will take the best medications or the best healthcare services in order to treat whatever the discomforts to you or to your body. So this kind of more hazardous behavior, it's going to inflate the healthcare expenditures tremendously. And also, well, ultimately, who paying for those expenses are the governments. So the government will have to collect a very, very high rate of tax from everyone in the country in order to pay off those expenditures. So a high tax payment is another problem in these types of policy, which the inflated healthcare expenditure will also inflate the tax burdens on the populations. Well, the two extremes actually has its own pros and cons. Well, let's take a look of the middle grounds of this study here that might be some policy that stand between the two extremes. Well, the compulsory insurance program, basically, it's a mandated insurance program. So this types of insurance program, it's a legal requirement for everyone in a population to purchase an insurance contract. It confronts the adverse selection by effectively banning it. So even a robust customers, as we discussed, a healthy body would prefer to opt out, are legally required to buy into this system. So as long as we can include everyone into the pool and effectively using the cost sharing mechanism in the insurance markets, well, the adverse selections will disappear by itself. Well, this system actually has several advantages. Number one, it reduces adverse selections in the insurance market because now everyone is required by law to pool together in one big pool. Not only just that, in the compulsory insurance system, well, government can involve as much as they want, or it can be completely private, run by the private markets. So that means, well, the law can set, well, everyone has to buy an insurance in the market, but well, it's not necessary to buy it from the government. It can be the populations or the citizens in the country. They basically have the freedom to choose where to get their insurance contract. Also, this types of insurance system also provide a minimum equity to every single one in the country. So as long as you have some sort of insurance, well, you will be able to get access to the standards or the most standard care in the country. It may not be a full coverage that the individual is purchasing from this under this types of insurance system, but still, at least it provides a safety net for everyone. Well, the cost for this type of insurance system is that this kinds of policy can be as expensive as the universal public insurance. So that means the public cost for having these types of insurance system might not be as a cost saving as compared to the universal public insurance, because well, most of the time the government will have to subsidize the insurance company in order to get most of the people on board. And the mandates must be carefully defined. So how full the coverage people must buy or require by law to buy, if this definitions of the coverage that require for everyone does not define clearly, well, it becomes a problem because you can imagine some people might actually buy a 100% full coverage when he or she doesn't need it, and someone might actually force to buy a partial coverage, which is required by law, and then he or she does not actually have enough coverage when something bad happens to him or her. So this kind of definitions has to be very clearly defined. So what type of coverage is required by law for everyone to get. Also, it induces the risk selections in the markets. So unlike the adverse selections, well, the risk selection, basically it's a behavior taken by the insurer. So insurer might actually seek out the healthiest people to cover or to insure in order to increase the level of profits. So in this types of insurance system, well, it still has its own strain, but then also just like how we lay out these topics, it never comes with a cost. The fourth type of insurance system or program that can be applied to the country is the employer-sponsored insurance. So everyone knows the U.S. it's applying this to the country. Everyone who get a jobs, you basically being offered by your employers for the insurance options. So that means as long as someone is working, well, you will be most likely be covered because otherwise your employer will be violating the law. So the good thing about this types of insurance program is that it will induce the robust people, which is the healthy bodies in the society, to voluntarily pool their pool with the frail co-workers, which is the sick co-workers or the sick people in the pool. So this create a cost sharing within the pool from the working places. So again, to avoid an insurance or to avoid adverse selections, one very particular way to do it is to have everyone pool their resources together. So as long as everyone buying insurance, well, adverse selections will never be a problem. However, the problem in these types of policy is, number one, it only provides a partial solution to a partial populations. So people who get a job, they will be insured by the insurer or maybe sponsored by the employers to get insurance. However, people who don't have a jobs, such as children, students, or retirees, well, those are the group of people that are not being covered fully with the suggested program. So it's possible those children or retiree may not actually get a insurance cover. On the other hand, another problem that might actually arise with this type of insurance program is the complications of switching jobs. So think about if you are getting a jobs that provides you an insurance and you have been working in this job for several years and you seek for a better job out there in the pool, well, you are basically locked up. So we call this a job lock situation, which we will discuss in the later chapters. But you can kind of see how it complicates the process of switching jobs within the labor markets. So the last options here that is described by the book is called the means test insurance. Well, this type of insurance program actually provides subsidized health care to the poor. Just like the Medicaid in the United States, well, it actually provides a safety net for people who have low income. It's subsidized insurance. It's not primarily intended to combat adverse selection, but instead it's to improve equity by providing health care to those who could not afford it otherwise. So the cost of providing these types of subsidized health insurance for the poor basically identical to the cost of spending or expanding the public health insurance to the poor So basically, it's just another way to do it. So in this types of health insurance system or policy, well, obviously it provides equity for everyone. So the healthcare for those who cannot afford it now will be covered. Of course, equity will be fairly increased dramatically in this under this types of insurance system, but then it doesn't come with a cost. Again, well, the main cost for this type of policy is the tax burdens on the taxpayer. So since the government is covering those people who are not be able to afford for the healthcare services, well, now those money spent in the country will have to share within the country. So we have talked about all the different types of um, policy that helps solving the problem of an insurance, or maybe in general for the problem in the asymmetrical information settings of the insurance markets. Now we are going to move on to talk about how the government policy should address the moral hazards problems, or how certain policy can limit the moral hazards problem in the insurance market. In the private insurance markets, the insurer, they can actually compete to offer customers the optimal mix of the insurance coverage. And also they have several tools to contain the moral hazard behavior, as we discussed in the previous chapter. Also, the customers in the private insurance market actually want some degree of moral hazards control so that it can be affordable to get the health insurance in the markets. But when things turning to the hands of the government, when the government is trying to run a public insurance program, well, it becomes a very, very difficult job for the policymaker to actually handle. Because now the policymaker, they have to actually find the balance of the trade-off between full insurance and tax burden. Well, let's take a look at some of the insurance controls options here. So some of the tools that we actually study in the previous chapter that contains more hazards include the health technology assessment, the HTA, the cost sharing mechanisms, co-payments, co-insurance, and number 3, the gatekeeping and queuing. So we might actually have someone to be a gatekeeper to actually keep track of whether the treatment is worth for the patient to use. And last, the prospective payment system. So in the case of health technology assessments, one very common tool to use is the cost effectiveness analysis, which we studied in the previous chapter. So the ECA basically it's a tool that gather information about different treatment options and determine which options actually generates most additional health benefits for the least cost. Well, the advantage for those for this types of insurance policy is that it will definitely limits the level of moral hazards. And by limiting the moral hazard behavior, it also reduces the total spending in healthcare expenditures on those inefficient and costly treatments. However, this type of policy actually makes the public insurance less full for the general patients pool. The fact that the CEA might not actually come down to the conclusions that has all the treatments to be approved. There might be some treatments that can actually help a person to extend their life, but if as long as the government does not found these treatments to be cost effective, well, they will most likely to reject for paying the treatment for the citizens or for the patients. So easily we can see this create a huge political controversial topics in the nations, because now uh, it actually related to how the life-saving treatments might cost so much for the government, and the government might actually want to save the money on spending those very expensive, inefficient treatments. So it's kind of like saving money in order to deny a life-saving treatments in those situations. So denying coverage for some treatment may be unappealing for political reasons. Some of the examples that actually suggest the government sometime might actually move away from this type of CEA analysis. Well, the example is the US Medicare. So Medicare, it's basically prohibited by law from using the CEA in its coverage decisions. So all the Medicare cover any medically effective treatments, no matter how expensive it is. Well, this, of course, cannot be applied to most of the public insurance um, coverage or public insurance system, because it's a very controversial tools to apply. So that's why the second options becomes more appealing. So which is the cost sharing mechanism. So the cost sharing basically is used to fight the moral hazards. In the case of providing some incentive for patients to contain the expenditures on those very expensive, inefficient healthcare services. So the cost sharing basically is the out-of-pocket cost that the patients who are insured pay when they receive the health care. So this out-of-pocket cost becomes a cost, initial cost for patient to get to those healthcare services. However, this can be problems too, even though the benefits for this type of policy is to limit small hazard to reduce expenditures. However, again, it also reduces the accessible for patients to those treatments in the market. Because the fact that people who are poor or maybe have a full-time job, 3 kids, low-income family, well, they still have to pay some cost in order to get to the access or get access to the treatments that they need. So this cost involved with the healthcare services might actually keep some of the people away from using the service that they actually needed the most. So example for this kind of problem is you can look at the US Medicare system, which they don't actually provide a full coverage for the patients. As of 2012, Medicare enrollee must pay the first $1,156 of expense for each hospital visits and the first $140 of outpatient clinic expenses each year. And also people under the Medicare system, they must also start paying $289 per day once the hospital stay lasts longer than 60 days. Well, obviously, this types of policy, this types of cost-sharing policy actually force the enrollee of Medicare to economize or purchase the supplemental private insurance in order to get the full service that they actually needed the most. So some of the low-income people might not equally getting the access to the very basic fundamental healthcare service as they needed it. So option number 3 is by controlling or limiting the moral hazards with gatekeeping strategies, or maybe by having a queuing-based policy. So gatekeeping basically is a tool that used to control and limit moral hazard by having the general practitioners, which in general we call them the GP, to satisfy the needs for a special appointment for patients. So by providing this gatekeeping mechanisms in the markets, well, the gatekeepers, which is the practitioners, will be able to provide the most professional advice for the patients to what they actually needed the most and most efficient. So instead of letting the doctors or physicians in the hospital to decide, the general practitioner can now be able to provide a second option for the patients. So as we studied before, there might be a possibility for physicians-induced demand. Without the information available in the markets, the patient might be lured to believe they need certain very expensive treatments that it's not very effective to their health. But with the general practitioner, it's possible that the second opinion might actually give a better option for the patient to make use of those treatments to get healthy again. And also, it contains more hazards, and by limiting the patients to make decisions on their own of what treatments they want to actually get. The public insurance system will also control costs by limiting the total number of specialists available in the markets. So for example, it's possible to have the governments to set a lower returns rate or reimbursement rate for people getting the special appointments in the markets. So by doing that, the income for those special treatments will drop dramatically, so that the income for those special doctors or specialists will actually be reduced, and it actually lower the number of the specialists in the markets because less people want to be those special doctors. Well, this actually helps to lower the possibility for this very expensive special treatments in the markets, such as the MRI image or other types of special treatments that require special skills. However, when the demand for the specialists actually overstrip the supply, well, waiting will become a problem. So the queues will result in the hospitals. So usually when people are waiting or they are in the queues, that means, well, the market is insufficiently providing the service to satisfy the demand. However, in the presence of the more hazards, waiting might be an indication of inflated demand. If so, the limited numbers of specialists might actually save the overall spending without sacrificing much of the health, because people who really need it, they will actually stay, but people who actually don't need that service or need that treatment so much, well, the waiting in line or the waiting time becomes a non-financial cost to those patients, and it will actually drive some of the people away by overusing or over accessing those health services. The queue-based system might be actually more equitable comparing to the cost-sharing system, because the cost-sharing system still people has to pay in a monetary terms in order to get the minimum standard service that they need. But in the case of queue-based system, well, now the cost it becomes time instead of finance or monetary terms. So both the rich and poor will get the equal chance to access to the care. However, there are still many different political issues can be brought up from this type of policy, because of the waiting time. Again, it becomes very frustrated for the patient who really needs the service in time, because people who want to actually treat their, let's say, a broken legs immediately, they may actually be sent back home by the doctors to say, well, to put them into a wait list for 3 months before they can do the surgery. Well, in between time, the patient might actually suffer the pain for several months before they can actually get the problem fixed. So the last options here is by creating the prospective payments to contain the more hazards problems. Well, traditionally, we always have a retrospective payment system in healthcare. So it's a payment that made after the service is rendered. And the amounts paid depends on how much healthcare it's received it. Well, one particular types of retrospective payment is called the fee-for-service system. So this fee-for-service system basically is the doctor can actually charge patients different services depends on what types of service they want to get or the doctor recommended. So the doctor has no reason to deny patients a service because the costs are just too high. Well, this system actually fosters trust between patients and doctors. Well, if the doctor it's paying the perfect rules to tell the patients what they really need, well, it's not a problem at all. However, in the previous chapter, we actually discovered there is an incentive for the doctor to actually suggest or advise for the additional service that the patient might not need. Well, those situations, it's what we call physicians-induced demand. Well, in order to avoid these types of behavior of the doctors or physicians, well, the prospective payment actually turned things around. So this alternative system, it's called the prospective payment system. So with the prospective payments, the payments are basically made to doctors or hospital before the healthcare is delivered to the patients. So charges are not based on the procedure performed, but on the conditions of the patient who is admitted. So an example of prospective payments may be a prospective payment system paid to the hospital, a fixed amounts of for treating any heart attack patients. Well, this gives the hospitals or the physicians an incentive to economize in the treatments of heart attack patients because they no longer receive extra payment for doing extra work. So whatever the conditions you are admitted to the hospital or maybe admitted by the physicians, well, either the insurance company who actually provide you the coverage, they will say, you know what, for let's say broken leg, we will only pay fixed amounts of $50,000. Or if someone is getting a cancer and the insurance company might actually tell the hospitals or the physicians, well, based on the previous history, we will only provide payments of $150,000 for the treatments. So this types of prospective payment system can be paid by the private insurance company or the public governments. This payment system has the advantage to actually limit the supplied the physicians induced demands and also providing a much better or cost effective treatments for the patients because well any non-health related expenditures will not be profitable from the hospital's points of view. Well, since the early 1980s, well, the governments around the world has embraced the prospective payment scheme as an effective way to reduce moral hazards and physicians-induced demand in the market. However, it does come with a price. After the introductions of the prospective payments in the markets, well, now the doctors and the physicians or hospital, they are basically taking over some of the responsibility for containing costs. So which means, well, in some sense, they do not want to actually suggest or advise the patients to take further treatments if it's not necessary, or maybe they would think that it's inefficient to treat the sickness. Well, it becomes a problem between doctor and patient because it definitely worsens the relationship between doctor and patients by the doctor not giving the treatments that the patient wanted the most, even though it might not be efficient, but the patients will always have the right to request uh, uh, more expensive treatments instead of the most effective treatments. So in one study conducted after the US Medicare program implemented prospective payments in 1948, the patient's mortality actually increased significantly at a subset of hospital in the months after the transitions. So not only the relationship between doctors and patient becomes a problem, but there are some evidence suggesting that the hospitals changing their behavior with the prospective payments system might actually directly contribute to the increase of mortality rates in the country. So how should the healthcare provisions be regulated? It's the last questions to actually address for the policymakers. As we study from the previous chapter, the private healthcare market actually has many problems. Well, problems include the hospitals usually running into a oligopoly setting where there are only a few big hospitals available in the city to provide the healthcare services. And with this limited number of competitions, well, they are willing to exercise their market power to actually charge a higher price in the market. Monopoly rents for doctors and specialists is another problem where the doctors and specialists, because they are so limited, high skilled in the markets, they can actually exercise their monopoly powers to actually gain profits by offering a much higher price service. Well, those incomplete or imperfect competitive markets will create an increase in price. However, on the other extreme, if we have too much of a competition, it will create a medical arm races, which actually also inflate the healthcare costs. So in the case of medical arm races, well, the competitions will actually force all the service provider to actually put out extra uh, healthcare services in the markets to convince people that they are more competitive ones in the markets. And those overuse of healthcare services or over implements to the patients, it will actually ultimately increase the level of health expenditures in the country. At last, the physicians-induced demands, it's basically what we cover in the previous sections, which also will cause a problems that inflates the healthcare expenditures in the country. So in order to set a policy to combat all these maladies without creating new inefficiencies that are even worse, it's the main topics for most political policymakers to address. So there are fundamentally three available options in order to regulate the healthcare market. Well, one is by the public provisions, which the government's completely taking over the healthcare service and make it public for everyone. And number two, well, the other extreme of this spectrum is to make this completely private market. So let the private firms run the whole markets of healthcare services. And number three is to have the governments interfere the markets by setting prices. So in the first approach, well, the governments can actually nationalize the healthcare markets. So in this particular approach, well, the governments will run all the hospitals in the nations. Well, the hospital will be funded by the tax, and also the physicians in this case will be employed by the government. So we are basically making all the hospital to be a public facility and also making all the employees in the hospital to be a public servants. Well, the pros in this kind of approach will definitely make the governments to take full control of the healthcare system. And some study actually suggests it's actually better for the government to control the healthcare expenditures or healthcare costs by a single payer. Well, it doesn't come with a cost. It doesn't come without a cost, actually. There are several costs or cons in this type of policy approach. Number one, some people actually suggest that by having only one agent in the economy to run the service, it might actually lower the quality of care as comparing to when there is a competition in the market. And the standard care in this case becomes a minimum care that people can get from the markets. Well, another problems in this types of approach is that the long queues will be formed because of more hazards. So everyone, they are basically just so in rush to get to the service because it will be funded totally by the government. So whenever people feeling some sort of discomfort, there will be the ones who get to the service, and overuse of these healthcare services will form these long queues at the hospitals. Also, there are other downsides about these types of approach. Well, some of the variable medical care might be restricted. The government might not be able to offer all the variables healthcare services to the market because it will now depends on whether the governments think it's worth to offer those services in the market. So there might be some very, very low cost effective medical services that it's not being introduced to the market, but it might save some lives in the healthcare system. Well, furthermore, not only the hospital does not run in an efficient way, but the workers working in the hospital might not have the incentive to provide quality care as comparing if they are running in a private firm. And at last, for most of the public-run hospitals, it's lacking of a feedback mechanisms or improvements. So for example, in the private markets, the hospital might actually find that they will have less and less patients to visit them because they are not providing a good enough quality of service. Versus if a good hospital running a very cost-efficient way, they might be able to get a lot of the patients in the market, and finally, as a result, they will get rewarded by the profits. When the hospital is run by public government, well, the problem is no one will be able to tell whether the government is doing a good job or bad job because, well, the patients will always overuse the services in the public, and you will never know which hospital will be it's running more effectively as comparing to the other. So this nationalizing the healthcare provisions approach will ultimately generate full equities to the public. But the problem of more hazards, the cures, the low quality of cares, and also restricting people getting access to the variable medications and all this other inefficiency in the markets will become a cost going along with this approach. The second approach, on the other hand, actually it's to privatize all the healthcare services in the market and let the competitions preserve the incentive for hospitals to operate efficiently. So the pros of this types of policy is to provide competitions in order to limit those inefficient outcomes, such as low quality of care, inefficiency workers, and also inefficiency pricing or quantity of the service. Also, under the competitions, because the price or the cost for healthcare will be going back to the equilibrium, usually it's higher than what is offered by the governments. Well, the price mechanism, it's going to drive those queues away, because at equilibrium, there will not be a shortage or surplus in the healthcare market. However, we are only assuming the market is running efficiently at the equilibrium. But if the case in the country where there are too much of the competitions, well, it will cause an inefficiency in quality competitions. And usually we call this a medical arms races. So under the conditions of medical arms race, well, the hospitals or the healthcare service provider, they might actually overusing the high quality treatments in order to gain the profits from competitions. Also, by letting the private firms running the hospitals or healthcare services, it might end up causing the problem of lack of access to the service. People who are earning low income or uninsured, they might not be able to get access to those healthcare services that they need. Sometimes the government might actually provide a supplement policy in order to help those people who are in a low income level or uninsured. And one of the policy in the United States is what we call the last resort law. The last resort law actually guarantees the people who are in need of the service, they will always get those immediate care, regardless whether they are insured or not, or what income level they are, or whether they are affordable, can be afforded for the service or not. However, in the case of last resort law, patients who actually get those emergency service and being discharged, well, the hospital does not have any rights to actually ask the patient to pay for the bills if they cannot afford it. Well, ultimately, the hospital will have to switch, or they're shifting the cost of this extra service that they provide to other patients, especially for those who have insurance. So again, providing these private provisions, it might help easing those competitions in the markets and solving the inefficiency, but it comes with a cost. What if the market is not competing at an efficient level? What if there is just too much competitions? And also, this high prices of or high costs of the service might actually drive some of the people away from getting access to the service that they need. So the third approach here is basically have the government set prices in the private markets. So instead of having the governments running the whole healthcare system or letting the private firms to run the market itself, the government can also interfere the price of the treatments or services in the healthcare markets by setting certain price ceiling or price floor in the markets. By providing those price controlled policy in the markets, well, it might actually keep the healthcare more affordable for the people in the country. So the true benefits for this types of approach is to contain the market power from the private provider. So for example, it's possible to have one hospital running in a small region, which providing them this monopoly power to overprice the service in the market. Well, in this case, the government can actually step in to say, you know what, we are not going to allow certain treatments or certain service to be overcharged. So they will put a price ceiling to some of the services in the hospitals so that they can maximally charge their service with that mandated price. Well, however, just like the government running the hospital or popularizing the healthcare markets, it also provides some inefficiency in the market if the price is not set properly. So providing those price controls should actually contain the hospital costs, but it also induce some preserved incentive. So in some cases, the hospital can actually refuse to provide some services in the market because the mandated price, the price control, the price ceiling might actually set it too low, that the hospital might actually refuse to offer those services in the market. So the end of the day, it's probably the patients may have to suffer without those available service in the market. So we have talked about several different policy or provisions of healthcare that address the three fundamental questions that we asked at the beginning of the chapter. So now, I would say there is none by itself. It's the perfect ones to solve the problem because we have seen all the trade-offs between different policies or approaches. Well, what's more useful to do is to actually look at different models for addressing those health policy issues or problems. Well, in general, there are three main health policy models that we would like to study, and we are going to study in the upcoming 3 chapters. Well, regardless how different the countries has its own set of policy for managing the healthcare markets, but each country approach can actually fit into one of the 3 board groups that we are going to introduce here at the end of this chapter. Those models include the Beveridge models, the Bismarck models, and the American models. Well, the Beveridge models actually is a model that actually developed by the UK. Well, in this model, basically is a model that has the governments taking over the country's healthcare provisions. So this model actually features a single payer insurance and the public controls of healthcare. Well, healthcare in general, they are basically available for patients for free. In these types of models, healthcare is a good provided by the government and pay for the tax revenues. So equity is the primary considerations of this model. And this model provides a full equity for everyone to get access to at least the basic standards care in the country, regardless the ability to pay. Well, the example for these models that apply in the world include, of course, United Kingdom, Scandinavia, Canada, Australia, and New Zealand. So those are the countries that has a very, very strong emphasis on equity instead of containing healthcare costs. Well, the Bismarck model actually is the reverse not so much of a reverse, but it's the middle grounds as comparing to the American models and the British models. So the mismatch model actually is a model featured with universal insurance, but with a private insurer playing a major role in the country. This model actually allows substantial private healthcare provisions. However, the healthcare services in this model are usually heavily regulated with price controls. So some of the country that it's applying these models include Germany, Japan, Switzerland, and Netherlands. Well, the Bismarck model actually provides a very good balance between equity and liberties. Well, the American models here, it's a unique model to the United States, which features the private market in the central rule. Insurance markets and hospital markets both are dominated by the private firms and run by the private firms. Universal insurance is not provided or mandated, so that means some portions of the population can be uninsured. The American healthcare system also incorporates some major features of the British or mismatch models, such as the public insurance, Medicare, provided to the Americans over age of 65, and Medicaid, which is a free or nearly free coverage for the poor. Well, this set of policy actually reflects a political emphasis on individual choice for patients and doctors, but also the concerns for equity. So the healthcare reforms actually passed in 2010 actually moved the American system closer and closer to the mismatch models by providing the universal insurance to the populations. However, it will still retain many of the unique characteristics after the provisions has changed. Well, in order to compare some of the countries' performance on healthcare and also health performance, we would like to actually use some numbers so that we can evaluate whether one country is doing better than the others based on this very, very basic variable. So in this diagram here, we're actually looking at graph where there are several countries plotted in the diagram, and the horizontal axis actually illustrates the health spending per capita. And on the vertical axis is the life expectancy at 65 for females in 2009. Well, as per this data showing, well, United States, obviously, it's way out there on the right-hand side, which means we are spending the most money, at least for health spending per capita. However, we have about 20 years of living, of life expectancy for female at the age of 65, as compared to, let's say, Switzerland. So Switzerland on this diagram actually pay much less as comparing to the US, but they are actually way up high on the diagram where they have a higher life expectancy at the age of 65 for females populations. Well, there are other countries out there also illustrate a much better life expectancies with a much lower cost as compared to the US. Well, Japan is the highest ones in life expectancies, but again, they are not spending that much of a money in order to get that level. Well, comparing this country in one graph, it's not fair to say, well, one country is actually doing better or achieving a much better health with less cost as comparing to the other, because we are only comparing one figure. And what's more important is, well, what if different country actually has a different inherent level of health? Or what if the people living in different country, they value health differently, so they choose different health level? Also, what if countries differ in how much health inequality exists? So if countries, they are actually diverse in any of this way, well then comparing the performance of each country in the previous graph will be a misjudge of the performance of the country. So the effectiveness of healthcare system in different countries should be judged in a different way, or maybe justified with the reasons that we raised in the slides. So in this diagram here, we actually give some idea of how things can be explained with different level of health approach with different level of health expenditures. So in the first figure, we actually assume all three countries, the UK, Switzerland, and US, they actually have similar characteristics. There's no difference comparing the three countries in terms of health productions. So the maximum health productions that we can achieve, it's basically lying on the HPF, which is the health production frontier. So both UK and also Switzerland actually are on the curve. But in this case, US it's not, so that means they are basically producing efficiently as comparing to the other. However, if there is any different characteristic that actually drive the US to have a different health production frontier as shown in figure B, well then the US it's basically doing as well as the other two countries are, because they are basically using all the available resources effectively or efficiently. It's just that we cannot produce health as efficient as the UK, but still we are basically effectively using the resources that we have in the country to provide the maximum health that we can capable to achieve. Well, this analysis here actually help us to understand, well, even country like the UK and Switzerland, as we saw in the previous slides, there might be country actually productively efficient to generate health and standing on a health production frontier. But they might actually choose a different amount of healthcare with different reasons. So for example, it could be true that the UK actually values more on educations or maybe other public service as comparing to healthcare. So the marginal dollar spent on other things might actually give more or produce more utility to the general populations as comparing to the marginal dollar spent on healthcare. So in this case, if UK is trying to achieve more of the health by spending more on healthcare, well, they may be allocatively inefficient. So it must be true that the government will spend different level of expenditures or healthcare expenditures based on what they actually values more or less in the country. So sometimes country can shift their activities or the spending on other activities as they would spend on healthcare. Well, in this case, well, some of the money spent on other things out, like spending on education, building more school, or spending on infrastructures, building more roads, instead of spending money on healthcare, it actually generally providing or increasing the overall welfare of the populations. So coming to the conclusions of this chapter, well, the government basically have a lot of policy options that they can choose to address some of the problems created by information asymmetries in the markets of healthcare or insurance. Well, as we have seen, well, it's almost impossible to solve every single problem all at one time simultaneously. Countries that have adopted policy that solve the adverse selection problem actually face a significant challenge in controlling the moral hazards. Also, we have learned the three challenges that we are trying to achieve in healthcare policy, but they all come with different trade-offs. So in general, there is no free lunch in healthcare. Policy provides more equities, either cost more or force people to wait longer for care. Policy that improve hospital efficiencies actually result in higher tax or sacrifice on equity. So it's probably too much to expect from everyone to be happy with the healthcare system. There will never be one that actually satisfies everyone's wants, as we actually discussed in the earlier of this chapter. However, finding that one system that fits us more, or maybe providing more benefits to outweigh the cost, may be the goal for most of the politicians out there. Well, in the next coming 3 chapters, we are going to study the 3 basic models in healthcare in order to actually get a better sense of how those models might actually benefit the society and what are the causes that involve. So I will see you next time.